This conference will now be recorded.
Okay, guys, so we're now recording. Everybody should know, and I will tell you who I have on my list, and then we'll see if I missed anybody. So I have Dennis Correa, Paul Frieda, Les Shelderup, Richard Wassersu, Carl Foreman, Jim Ward, Jim St. James, Bob Bordiger, and then Sierra. Is there anybody I missed?
Hey.
Oh, Jake. Christmas. Sorry, Jake.
It's all right.
We just take it for granted, Jake.
I know. I knew I was here. Rick knew I was here. He was talking to me.
Oh my goodness. Sorry, Jake. Thank you. That's why I do this. And so we have, I think Bob, you haven't been on the call before, have you? Or were you on last week?
I was on last week.
Oh, you were? Okay, good. So we have a couple of people. And Jim, have you been on our call before, or have you only been, Jim St. James, have you been on our call before, or have you only ever been on Peter's call?
I've been on your call and Peter's, but it's been a while. I did 4 months of chemo, so I kind of dropped out for a while.
Right. No, I just couldn't remember if you were ever on this call. I know you were on Peter's call a fair amount. Okay, well, I'm just asking just to see if we have anybody new, and it doesn't sound like we do. So let me run down and see who would like. Oh, and now that we have everybody here, in honor of Professor Wassersug, is there anybody who can do a good rendering of O Canada? Jake declined.
What? We lose all. If I sang, Rick, we lose all of our callers.
Okay, well, in that case, we'll just wish, all of us will wish our lone Canadian, well, he isn't really a Canadian, but our lone pseudo-Canadian on the call today, a happy Canada Day.
Wait a second, Richard here. I'm the person you call professor. I want to speak in my defense. I do carry a Canadian passport, and I admit I do also carry a U.S. passport. And the fact that you guys can't sing "O Canada," which I won't do, but you also have an advantage. I want to point out that you have a flag, the Star Spangled Banner, and you have a national anthem, the Star Spangled Banner, and they match. And we are disadvantaged. However, there is a solution, and maybe you guys can help me make this an international movement. If we can convert our national anthem to Scott Joplin's Maple Leaf Rag, then we would have the anthem and the flag match.
Okay, all right. Well, we'll certainly take it into consideration. Did somebody else just join, or was it just Bill Franklin? Oh my goodness.
Hey Bill, welcome Bill.
Hey,
Hi, Bill. Okay.
So I can figure out how to unmute this.
That's okay. It's good.
Just got here, don't mute.
Okay. So let me run down the list and see who would like some time today, and then we can get started. Dennis, anything for you, sir?
No, thank you, Rick. I'm all set.
Okay. Paul Frieda, anything for you today?
Nothing for me today, thanks.
Okay. Les Shelderup, anything you'd like to talk about?
If you have a few minutes, I would appreciate it. Thanks.
We do. Richard Wassersug, anything you'd like to talk about?
I am still seeing myself as an observer, trying to understand how online support groups work. So I'm fine, other than just collecting informal data here.
Okay. Carl Foreman, anything you'd like to talk about?
I think this is one of the few times where I do not.
What? Oh my gosh. I'm glad I'm sitting down. That's all I can say.
That must be good news, Carl.
That is
so
good
far.
news. Okay. Jim Ward, you need to give us an update as to how your treatment planning is coming along?
Sure. Yeah, I'll be happy to provide a brief update. Thank you.
Okay. And Jim St. James, you can definitely update us on how your treatment has gone with the chemo, if you don't mind.
Sure.
And Bob Bordigo, would you like to bounce some more thoughts off of this august group?
I would, yes.
Okay. Len, anything you'd like to talk about today?
No, thank you, sir. I'm good.
Okay, Jake, anything you would like to talk about?
If there's time, I think these guys are sick of hearing about me, but yeah, if there's a few minutes at the end.
We are not sick of hearing about you, okay? Okay, just saying. Isn't that true, Len?
Absolutely.
Thank you.
Yeah.
Larry Fish, anything for you today?
Hi, guys. No, I'm good tonight. Thank you.
Okay, and Mr. Franklin, look at that shirt. Oh my gosh. Ooh. Oh,
Homemade.
tie-dye Franklin.
Yeah, by my
I
dog.
thought maybe you mugged Peter Kafka.
Yeah, Peter's got one. Peter's got one just like it. No, I looked at the name list, and my name is right next to Bob Bordiga, and I saw Bob Franklin for some reason in my mind, and I thought, holy crap, my brother's on the call. But yeah, I got something I can bring up if you got time. I don't think I can stay the whole 2 hours, but
Okay, we'll promote you.
no, I'm
give
not
you-
asking for that. Just if you got time.
Well, we'll give you we'll give you a little or it's called a board boost.
All right.
Okay. Okay, so we should have plenty of time. We've got 6 folks that would like some time right now.
Just as an insert, yeah, I have to leave about 2:30, 2:35. I have an appointment, so I can't stay on the whole thing either. This is St. James.
Okay, St. James. Well, can you wait a minute? We've got to translate that into our time. So you've got to leave about You've got to leave in about 20 minutes. Is that right?
Correct.
Okay. Well, then I'll tell you what. We'll kick off with you so that we can make sure you get some time.
Oh, okay.
Why don't you tell us what's been going on with your trip? Fill the guys in a little bit on your background, because some of them don't know you, and so they'll have a better understanding about what you're dealing with. I know a little bit more, but they don't.
Yeah, my trip's been a little bit different. I'll go over real quick and then tell you where it's at. At the end of 2017, I was biopsied and had prostate cancer. I actually went to get laser ablation done. At that time, the same time, I had a 3T MRI, and I saw that it metastasized into my pelvic bone. I decided to have the ablation done anyway. Came back to Maui and had radiation done on my pelvic bone. And for a number of months, everything was fine. I also did a little bit of immune therapy in Phoenix afterwards, just as a, preventative. I was doing fine. And then apparently I had some scar tissue at the bottom of my bladder, and I had that reamed out, turped out, I guess, at the bottom of my bladder. And about a month after that, my PSA went from a steady, like it was a steady 3 or 4 to 20. And then in 2 or 3 months, it went up to 100. I did a trial PET scan in January, I believe, or January at UCSF. Peter helped me get into the trial PET scan for the gadolinium 68. They saw that I had numerous hot spots in different lymph glands and a couple spots possibly in my spine. And in early March, I started 6 rounds of Takatier chemotherapy to address that. I had too many small spots. It was small tumor spots. It was picked up by that gadolinium 68 scan, but too many spots to radiate. So I had 6 shots of chemo once every 3 weeks since March. My last one was last week. I got a CAT scan that I need to get interpreted by UCFS oncology and my oncologist here to see, exactly what's going on. There were some questions, but they needed to look at my previous scans to tell me if, what it looks like. But I know that there was nothing in the soft tissues or in the organs, so that's the good news. I don't know about the bones. They have to, give me an update on that. So I went through the chemo. That really sucked. Really sucked. And I'm on the other side now, kind of recuperating from it and the side effects and all that. So that's my story. So here I am.
So, was the chemo rough on you from the beginning, Jim, or was it just cumulative, and by the time you got to the second or the third, you were feeling pretty rotten?
The first two, the chemos, I don't think affected me too much. I could even play tennis. I got a little bit tired and whatnot, but I was exercising. The first chemo, after the chemo, they give you a Neulasta shot, and that makes your bones produce white blood cells. So you.
60. It's a 2-day parade of epic deals, from electronics to fashion.
Okay, I just muted Paul Frieda. Go ahead. Sorry, Jim.
The shot the day after each chemo, they give you a Neulasta shot, and that makes you produce white blood cells in your bones. So your immune system could beef up right away. That hurt. That gave me lots of bone pain the first two times. That was real nasty. It felt like people were just taking sledgehammers and just hitting you all different places, and you never know where it's gonna pop up. That was real nasty. And then that got better a little bit. And each chemo is a little bit, harder, a little bit longer to recover from. Instead of 3 or 4 days, it became a week. About the fourth chemo, it became 2 weeks. After the fourth chemo, my nails were getting bad. I was getting a little bit of myopathy in my fingers, so they cut the dosage down, which did help. But then my back started hurting really badly, and everybody thought it was the Neulasta, because the Neulasta basically swells your bones swell to make white blood cells, and that'll pinch nerves and all kinds of problems, with that. So the last chemo, I did not get the Neulasta shot. The oncologist said, just don't get an infection. Just give yourself 3 or 4 weeks to really get your white blood cell count up naturally, instead of pumping it in like this Neulasta does. So now my back's getting a little bit better, but for 3 weeks I could hardly walk after the fourth chemo. It was just, it was kind of like a terrible sciatic on both sides of my legs. It was just nasty. But it's getting better now, and things are getting a little bit better. I did try CBD and THC a little bit, and I'm kind of experimenting with that, and I'm not sure, where I'm going with that yet, but maybe eventually I'll share it with everybody.
Did you have the Neulasta pump, or did you get a shot?
No, I had everything IV, and the Neulasta. The Neulasta I had. The chemo was all IV. The Neulasta I had a shot, but the last 3 of them, it was I forget what they call it. It's like a patch. They put it on your arm. It's a little machine on your arm, and then it shoots into it, automatically the next day. It wasn't a pump in your chest or anything.
Right, and was there a difference, do you feel, when you had the little gizmo on your arm versus when you got the Neulasta shot?
I felt well, the first one was a shot and it killed. It was terrible, so it wasn't any worse than that when I had the other thing. I thought maybe that I could get half the dose of the Neulasta, because on my labs it showed that the white blood cells were higher than normal anyway. But from what I understood, what the nurse and the doctor said is, no, that's kind of like the regular dose. You could get a different, a different shot of a different whatever medicine, and that is a shorter lasting one, and it's not as bad, but that was water under the bridge already.
And what about nausea and did you have much nausea and were you able to eat throughout?
I had gained weight during the chemo. I had no nauseous times. I think people told me it was the Lupron that made me hungry, that if anything, I had to be careful not to eat too much.
Yeah.
And then towards the end, the last 2 or 3 weeks, I'm always hungry, but when I eat, it doesn't feel any better. I'm just hungry whether you eat or not, just filling up your stomach. So that's been an issue.
Well, the trick that I found with hunger and Lupron, because it's really common and we don't talk about it much. We talk about gaining weight, but one of the reasons is because your metabolism slows down and you're always hungry and you tend to eat. And the trick that I used to eat a lot of celery and carrots, because they do fill you up and they don't have many calories, and it actually worked.
Celery and carrots.
Yeah. So I'm just, it's just a good little trick to have up your sleeve. Try it, and it fills you up. But I'd like to throw this open. We've had guys on this, and we have guys right now who have had issues around their white blood count. And anybody like to talk to Jim about his experience and what to expect now that he's through with his chemo? Or anybody got any questions about his chemo?
I have a question and a comment. First of all, Jim, I wish you would have checked with us, because a lot of people take an antihistamine when they're on the Neulasta, like Claritin. And that,
I was taking loratadine when I was on it.
is that an antihistamine?
Yeah,
it's the same. I think it is Claritin.
It's Claritin, Jake. Yeah.
Did that help?
Not really. Yeah, I did. Not in the beginning. It was so painful. It may have helped later on. I don't know. You don't know how bad it could have been.
Okay. It was just a thought. And then I have a question. I didn't hear, you may have already said, but your PSA had gone up to over 100. Did the chemo bring it down?
Oh, yeah. I'm down to 4.6 now.
Oh, pretty good.
Well, they put me on Lupron right away. I had that double shot while I was in California right after the MRI or the PET scan. And I forget, the 2 shots in the stomach, I forget what the hell they call that. That was net. What's that?
Permagon?
Yeah, I think that's it. I'll never do that again. That was nasty. That brought it down right away. And then I had Lupron, a month or 2 after that. So the Lupron and that brought the PSA way down, even down to 12, I think, before the chemo even started.
And who's your quarterback doctor at UCSF?
Dr. Borno, Hala Borno.
Yeah, I know of her, but I don't know her. Do you like her?
Yeah. She answers in my chart, and she coordinates with Okazaki here. And Okazaki here is willing to listen. She suggested not to take Xgeva yet, and Okazaki's agreed with that here on Maui, saying that, well, he was just giving me that as a precaution. And I'm going, I got enough crap in me. I don't need more stuff,
Right.
So yeah, they're kind of working together. I find out a lot of it is what the doctors kind of like to do or what they think. It's not real science. A lot of it is like go with the flow kind of stuff.
Yeah, Peter's just arrived, so Peter, we're just catching up with Jim St. James before he has to leave.
Okay.
So no problem. This is, guys, for those of you listening, and I know there are some of you, and again, you may want to ask Jim questions on this. This is a great example of how a good GU med onc at a quality center of excellence can work with a distant medical oncologist. In Jim's case, it's somebody at Kaiser Permanente on the island of Maui in Hawaii. And I know that some of you have faced that issue where you would like to get the docs working together, and this is a good example of how we can do that. Anybody have any questions on that? Okay. Anybody
Rick,
have any questions at all?
Just as a point of clarification, Kaiser runs the hospital financially, but it doesn't. It's still like a Blue Cross Blue Shield type of situation. The doctor is not a Kaiser doctor. He just happens to be at the hospital. Happens to have been taken over by Kaiser financially, but it's still an open hospital for anybody.
Right, but it's still a good example, Peter, of a a specialist.
Jim has a UCSF
working.
doctor.
Sorry?
Yeah, Jim's UCSF doctor is working with this doctor who's not a doctor doc, but just a med-onc here.
Right. So, I think that's a really good example. Jim, do you have any questions for us?
Well, I don't know where my future lies. I've talked with Peter about, I sent the results of the latest CT and bone scan to California. I haven't heard from Borno. I see Okazaki on Friday. And my main line for staying happy and positive is Peter. When I get down, he kind of helped me out because I kind of took a dive for a little bit. But everybody needs a Peter in their life. So there's my plug.
Thank you. Yeah, we know that. And we're very lucky and appreciate that as part of our team. So, yeah, great job, Peter. Okay. Anyone else have anything they'd like to say before we lose Jim?
Yes, Jim, how old are you?
69.
Okay, and you were first diagnosed how long ago?
2 years ago, end of 2014.
Have you ever had any genetic testing?
I did. BRCA2 came up.
Ah, my brother. Okay.
Mm-hmm.
You and me both.
Yeah, I was going to ask about that. Yeah.
Well, that changes everything, doesn't it? So your next step should be maybe olaparib.
I don't really understand the next step. Peter has talked about it, but I haven't really had enough time to research. Between the chemo head, just feeling like crap, I haven't had time to really look at the future with BRCA2. I did tell the oncologist in California I sent that DNA, results. So I'm waiting to see what she says, if there's anything in California over there that's new.
Well,
yeah, I would definitely recommend, and I've mentioned in this group before, that with me also being BRCA2 positive and being susceptible to aggressive prostate cancer, which I am, 3 months ago I started on olaparib, a PARP inhibitor, and my latest PSA based on that, and it dropped from 0.55. It was low, but now, and was rising from having been on Zytiga for 6 months. So Zytiga failed, went on to olaparib. My PSA is now less than 0.01.
Oh, wow. Well, what's the name of that? Yeah. What is it called?
It's a PARP inhibitor, and that any of us who are BRCA2 positive should really consider the possibility of going onto that medication, because it's been shown to have huge percentages of success. Up to 80% of those who take it have had a positive effect on PSA. So it's a PARP inhibitor. It's one of the first ones, olaparib. Rick has discussed there are now second generation type of PARP inhibitors as well.
How do you spell that?
P-A-R-P.
Jim,
I think Peter told me about it. I'll talk to Peter. He knows everything.
it's in the email from the other day to you that we need to talk on Friday with. And,
so
and you need
let me just ask you: are you the test that you did? Was it a germline test, or did you get a tumor sequenced, or get a blood test? What type of test did you do to find out that you were BRCA2 positive?
A saliva test, I think.
Okay, so you are okay. So that's kind of important. So you have an inherited mutation, which means a whole bunch of things that Peter's probably reviewed with you. But one of them is that this could be passed on. So if you have kids, then they need to know that you're BRCA2 positive.
Yeah, I told my brother and my nephews in that. So I did do that.
Okay, and they may be able to go to the same place you went to for that saliva test and get a discount in terms of their test, but it isn't really an issue of money, but it is really important. Secondly, you have to be really careful if you do any sort of radiation. And I know you've had some radiation in the past, but we've had men who are BRCA2 germline, and they are much more sensitive to radiation.
In what way? It spreads it or makes it worse?
The cells are more sensitive, so you can react. The cells can react. The healthy cells, you have BRCA2 mutation in every cell in your body. So that means that even the healthy cells can respond, and what can happen in some men who are BRCA2 positive is that they have exaggerated side effects, amplified side effects, because they're BRCA2 positive. Because they're BRCA2 positive, and that also I don't know enough. I'm not sure about the chemo, whether the BRCA2 positive would have affected the chemo. That's a question for Professor Bill, who isn't on the call today. But you and Peter can reach out to Professor Bill, and you can ask him whether the chemo. I mean, he's doing chemo right now. So, that might be an issue because he's BRCA positive, and he's also a genetic researcher, so he's much more familiar. The PARP inhibitor is the drug of choice for somebody who's BRCA2, as Carl mentioned. If the disease were to come back, or your PSA were to start climbing now, then for sure you would take it. And, it may well be that does Borno know you're BRCA2 positive or not?
Yeah, I sent that. She does now. I sent that information in.
Okay, so she may well recommend that you do start a PARP trial, or start using a PARP. It's not approved by the FDA for prostate cancer yet, but most of the insurance companies will allow you to use a PARP inhibitor if they know you're BRCA positive, because they know that there is a response. But there may also be trials. I think there's a trial going on right now at UCSF for rucaparib, which is, or Rubraca, which is another more stronger, more potent PARP inhibitor, and Peter knows what we're talking about, so he'll walk you through that, or you can call me anytime and we can help you with that. But yes, it's a very important disclosure, and I'm grateful to Carl for asking you that question.
Yeah. Also, Rick, you also had referred to me to meet with Susan Dumchek in Philadelphia because she's one of the top BRCA researchers, and you did say there's another woman at UCSF.
Yeah. So what you might, thank you for reminding me. What you might want to do when you speak to Borno is to talk with Pamela Munster, M-U-N-S-T-E-R, Pamela Munster.
Okay.
And she runs the BRCA clinic at UCSF.
All right.
And there are also a couple of other doctors at UCSF who are doing BRCA research. I don't know which of the GU medoncs there now is actually looking at BRCA in the prostate cancer arena. Borno would be able to tell you. It might be Terry Friedlander, but I'm not certain. But you and Peter can try and track that down, but failing that, Pamela Munster, who runs the whole kit and caboodle, is really good. But ideally, what you want to do, I mean, I couldn't do this for, I couldn't really do this for Carl because I don't know the players over at Abramson where the other clinic is, but you really need to find out who the prostate cancer doc is that's focused on BRCA. And
Okay.
Borno should know that.
Right. Okay, thank you.
Thanks, Carl. But yeah, there's a lot, and by the way, the reason why there's so much focus is because the president of the Cancer Research Center,
My mom's trying to call, but I don't want to go on call waiting here.
Alan Ashworth, he's the guy that discovered the BRCA gene. So the guy who discovered the BRCA gene, he's a Brit, is the president of the cancer center at UCSF. So yeah. All right, we'll move along. And who else told me they had to leave early? Bill, was it you?
I'm going to have to go soon, so I'll listen for a few more minutes and then I'm going to sign off. Thank you, everybody.
Okay, you can listen to the recording too, Jim. We record this.
Oh, right. Okay.
Okay. Peter,
Thank
I'll help you.
Do we have your email, Jim?
Yeah, we do.
We have your email so we can notify you of the calls?
Yes.
Yeah, we do.
Yes.
Okay.
Yeah, we do. Mr. Franklin.
Yep. Yeah, I only have till about 9 o'clock. So I've been experiencing an interesting phenomena. Sorry, I haven't been around for a couple of weeks. I've been really busy with work. I was in Hawaii, Peter, but I was working 7 days a week while I was there, so I wasn't really doing much anything but working.
There's
yeah,
7 days in a week here?
Yeah, there
I didn't
is.
think there was 7 days in a week here.
I think that's just a Joint Base Pearl Harbor Hickam. Those military guys, they work hard. Yeah, so 3 days before my trip to Hawaii, I'm driving to work, and all of a sudden, got a strange feeling in my left cheek, just right on the cheekbone below my eye. It went numb, like kind of like the feeling when Novocaine's starting to wear off after the dentist. Okay, that's weird. Then it kind of spread across my face and down along my jawline, but it was all on the left side of my face. So driving along, and I'm thinking, okay, am I starting to have a stroke? And I know all the signs of stroke, and I know all the little things to do about stroke because my father had a couple of them. So, but no symptoms, no weakness on the left side, nothing like that. So I called my doc, and she asked me all the same questions, and she's in the emergency room. So I went to the room, they did a full blood workup, and they did a CT scan, and nothing in the CT scan. The only thing the blood work showed was I had really low blood calcium levels. So they gave me an IV for calcium. And then I went back to work after that. The numbness went away after about 4 or 5 hours. So since then, it's happened 4 times. It happened twice in Hawaii. In Hawaii, they said, I called my doctor again. I said, it's happening again. Can I get like a referral to a neurologist or something? I don't know what's going on. So she said, go to the emergency room again. So I went to Tripler Army Hospital. I'm retired military. Some of you guys know that, some don't. But I went to Tripler. Great facility, by the way. And because I'm retired military, it was completely free. They did the exact same. I told them exactly what happened before. They did all the same stuff. Scan, blood work. No low calcium or anything this time, but CT scan showed nothing. They said, we don't know what's wrong with you, Mr. Franklin. Go back to work. And yeah, like I said, it's happened 3, 4 times now, 5, I think. I did get a referral to a neurologist. I wonder if anybody else has ever experienced something like this. Not that it's necessarily connected to our prostate cancer or anything like
that. Well, you know, I think the referral to the neurologist is the key here.
Yeah.
Do you have any neurological diseases in your family?
Oh, yeah, my dad had Parkinson's. So
that's what I thought.
Yeah.
I was going to say that, but I also know there's a guy down the street who had Parkinson's, and I was thinking to myself, was it his dad or the guy down the street or both of them?
It was my dad and the neighbor.
Right.
I thought my grandfather, my paternal grandfather also, my father's father had it, and my father's brother had it. So,
well,
none of my brothers have it yet, and my other brother's well into his 60s. So,
you know, and your doctors are aware of that, right?
Oh yeah.
Well, that's the first thing that comes to my mind, because I think that people with early Parkinson's, that's some of the, I mean, I don't want to scare you, but I think I have heard that as being symptoms.
Yeah, I did a lot of research on that, and I actually talked to my neighbor, and he's been pretty active on researching it and learning all about it. And he had not heard anything like, you know, just cheek numbness or facial numbness. When you first mentioned it, so.
Well, I mean, I've heard of numbness. I can't tell you whether it's, you know, facial or where, but I have heard of numbness as a symptom.
Right.
There's also, and I cannot for the life of me think of the term for it, but there's a thing that affects your face, and it can sometimes mimic a stroke, but it's not, and it usually goes away. And I cannot for the life of me think of the name.
It's Bell's palsy. Bell's palsy.
Thank you, Carl. Yeah. Did they mention that perhaps as
nobody mentioned Bell's palsy. I've actually heard that before, but
did you have any drooping of your mouth or anything, Bill?
Did I what?
Have any drooping of your mouth?
No, nothing like that. No facial drooping or mouth or weakness on either side or anything. Just like I said, it feels like Novocaine, like when Novocaine wears off after the dentist.
Right.
That's it.
I want to ask about that when you do go to the neurologist. Of course, you'll probably know about that anyway. But
yeah.
Bell's palsy. Thank you, Carl.
Other than that, I've been doing pretty good. You know, so.
Anybody else have any ideas or thoughts or suggestions for Bill?
I've got a friend in the Bay Area, longtime friend, who had they call it facial neuralgia. It affected his eating, his mouth. I mean, it was temporary. It went away, but it drove him nuts. He's kind of a, doesn't have it, but for a couple of months it was. And he was on Lupron. He was on Lupron. It was wearing off. He wasn't taking. He was ending the cycle of Lupron. And we thought maybe it was because of that. We didn't know. He seems. I saw him the end of May, and he seems to be doing much better. But he was slurring words. When this would be pretty dramatic for him.
Right. No, I didn't have any slurring or anything like that either. Until I checked all that.
Good.
That would be a really delayed response to Lupron. I've been off going on 2 years now. So.
Yeah.
Yeah. So wouldn't I'm just related. That's the only person I know that's had that similar.
Yeah. Yeah. My testosterone hasn't come back to any significant number after Lupron, but so that's one long effect of Lupron.
When's your appointment with the?
I have not scheduled it. I have not scheduled it yet. I got the referral last week. I was in Hawaii, and I didn't call him until I was going to call him this week when I got back, and I neglected to do it today. Just work.
Bill, Richard Wasisek here. Just to throw a couple things in. So the numbness of the face in the skin is Bell's palsy, and it's the 7th cranial nerve. The problem with closing your mouth, chewing, and pain in the face is the 5th cranial nerve. So they're two different syndromes, but in both cases, you're absolutely a good candidate for going for a neurological workup.
Right.
It sounds like you have trigeminal neuralgia, which is the 5th cranial nerve. It sounds like you have Bell's palsy, which is the 7th, or some version thereof. But either case, it could be deeper and more central, and therefore it does warrant a good workup. As for the hypothesizing about whether it's Lupron dependent or not, I will express my bias here, but the book on androgen deprivation therapy does not list either Bell's palsy or trigeminal neuralgia as documented side effects of Lupron.
Yeah, I didn't think it was Lupron at all. I've been off of Lupron for 2 years now. So
we're going to give it a new name, Bill. Bill's palsy.
Yeah.
But let us know. That's interesting to me, and I'm curious. I was an anatomy professor before I was a prostate cancer patient, so the stuff interests me.
All right. Well, that's more useful for us prostate cancer guys. Those of us that are like in IT and stuff. I have nothing to offer you guys.
I wouldn't say that. I would beg to differ.
Oh, I would too. And there's some wonderful tech imaging that requires incredible computational skills.
Oh yeah,
they're doing much more than anatomists are doing to help improve prostate cancer care. So there.
Okay, well, just keep us posted, and feel good, and I hate to bring out the old hackneyed reason, but I mean, I wonder if it's stress related because this big job that you just took on, and
yeah, I thought about stress, but I'm pretty good at relaxing, medication, mindfulness routines, and all that. No trouble sleeping whatsoever. When I was really super stressed out, it would manifest a lot as sleep issues. Definitely, I'd wake up in the middle of the night and just think about work for 2 hours. Just totally stressed out. I don't have that issue anymore. I can wake up in the middle of the night and go right back to sleep. My work doesn't bother me.
Okay.
Because worst comes to worst, I'll just say I quit. So,
Bill, it can actually happen. Right. I mean, like Professor Wasisek says, get a neurological workup, but it can actually come from like air conditioning blowing on you while you're sleeping, a fan blowing on you. I mean, it can be something as simple as that. Have you noticed?
Well, no, it comes and goes, and it comes and goes. at different times, and it's been in different situations. Driving a car, sitting in my office at work. I was walking to a restaurant in Hawaii. Just it was a nice mild night too. So I don't know. I do sleep with a fan blowing on me. Not really cold, but just a fan. The airflow is what I like.
That's a thought.
All right.
Good luck.
Yeah, thanks.
Okay. Well, thanks. Stick around for as long as you can. Brighten up our day with that shirt, and we'll see you soon.
All right, man.
Okay, let's go on to Les Shelderup, who's been patiently waiting since I bumped him out of the #1 spot, the leadoff spot.
Okay. A quick 30-second summary, I guess. At the age of 69, I was diagnosed with Gleason 10 prostate cancer in February of 2013. Put on Fermigon and had 42 external beam radiation treatments and continued on Eligard for a total of 2 years. Soft hormone treatment for 2+ years. In February 2017, Mayo removed 33 pelvic lymph nodes, 18 of which were malignant. C11 choline PET scan revealed 2 spots on my spine. So in January of 2018, they did cryoablation on those 2 cancer spots and put me on Lupron at that time. And they did 25 proton beam radiation treatments to pelvic lymph nodes in the September-October 2018 timeframe. Okay, a week or 2 ago, one of the callers who was on Lupron, I believe, said he was about to embark on a 120-mile mountain range hike. I could not make 120 yards mountain hike. Several weeks ago, Lynn had commented to another caller that it experienced an excessive amount of lack of endurance while on Lupron, that there could be a chance that the cause could be another issue, and it would not hurt to see a cardiovascular doctor. I was scheduled to see one in 2 weeks, so when I did, I informed him my situation and asked if there could be anything that would explain my lack of endurance. Following a couple of tests, he said that he could not find anything in the CV area that would cause it. Months ago, when I went to my family doctor, did my annual complete blood profile. I asked him if there was anything in the blood count that was out of line that could explain my lack of endurance. He said no. Of the other possible side effects of Lupron, I have very little. My hot flashes early on, I called warm waves because they were rather minor, and I've had no weight gain or any of that sort of stuff. So there's very little other things other than the endurance problem. I was put on a Lupron a year and a half ago, and Dr. Kwan recommended at least 2 years. So, last time when I saw Dr. Kwan from Mayo Clinic, he indicated that if I continue to have this endurance problem, that he may take me off of Lupron early. Well, my next appointment with Dr. Kwan is next week. So I'm wondering what I should say if he asks about going off Lupron because of this issue. Any comments?
Well, I'm going to let Len take a bash at this first, because Len's the master of intermittent hormone therapy.
Right.
And I'd like to know what Len has to say. Just remind us one more time. When did you first go on Lupron?
A year and a half ago.
January. And that was the very first time, correct?
For Lupron, yes, but I was on Fermigon and Eligard early on. Eligard, right. I guess it's the same thing.
Right. So, when did you first go on the Fermigon and the Eligard?
I went on that immediately in February of 2013.
Right. And how long were you on that time? When did you come off of it?
In 2 years.
2 years, okay.
On it for 2 years, then off it for a little over 2 years, and then on it now for a year and a half.
Okay, that's what I'm getting at. So that's the information I think Len needs. And also, what's your current PSA?
Negligible, less than what, 0.1.
Okay. Len, go at it.
Yeah, Les, that's pretty remarkable that you were a Gleason 10 going back to 2013, and here we are 6 years later, and you're less than 0.01 PSA. That's fantastic.
Right. They gave me less than 2 years to live at the time.
Yeah. Yeah. So something's working there for you, whatever it is. And my opinion, you deserve a break from ADT. Do you know what your H&H is, hemoglobin hematocrit?
No, I do not.
Because I recall that Peter was feeling a lot of fatigue, and his hemoglobin and hematocrit were in the anemic range. I think they were less than 10, right, Peter? Your hemoglobin? Yeah.
I don't remember the specifics, but my family doctor had gone through all the blood tests, and he said he saw nothing out of line that would cause any such endurance problems.
Okay. All right. So maybe you're not anemic. Maybe it's just the many years that you've been on ADT, and I think you should talk to your doctor about a drug holiday, just to see how you respond to it. Hopefully, your T levels, your testosterone levels will recover, and you'll feel stronger and more energetic. Unfortunately, there's no guarantee that that'll happen, especially since you've been on ADT for so many years. But it's a definite conversation you need to have with your doc.
What is the likelihood? The concern I had is the likelihood of things getting away from us if I am off of ADT for a while. What are the odds of things just getting away?
Yeah, I think that also depends on how your T levels respond to the drug holiday. If your T levels never recover, you probably won't see much of a difference in your PSA progression, because it's the low T levels that keep your cancer in check. You know, if it makes you nervous to be on a drug holiday, you can have your PSA checked every month. And if it gets to some predefined point that you and your doctor decide together, then you can go back on ADT. But if it were me, I would definitely have that conversation.
Yes, you definitely will. One of the other things, being on Gleason 10, having Gleason 10, they claim that the odds are much better that there may not be a correlation between PSA and cancer. That with Gleason 10, that your cancer can be running wild and PSA still remain very low. Now, one person I had asked a doctor, wasn't Dr. Kwan, but a different doctor, if in the past there seems to be a correlation that when my PSA started to go up, they did a PET scan, and sure enough, cancer was starting up. So far, there seems to have been a correlation. Now, if there's been a correlation in the past, is it likely that there will be a correlation in the future?
Well, no guarantees, but hopefully that will continue. You could always have. When was your last scan?
A PET scan?
Yeah.
I forget right offhand. It's been about 6 months ago.
And it didn't show anything.
No, it did not.
Well, unless you're
really track your.
Let me just get this one last thought in, Peter. Unless your cancer cells are not only not producing PSA, but they're also not producing PSMA, which is what they're usually checking for with the PET scan. A negative scan means you're doing fine.
Yeah, it was 1st of March. It was 3 months ago.
Yep.
Peter, go ahead.
You and I are in the same game here, with stuff coming back. Yeah, so I'm on intermittent and I'm off. And to me, my experience is that it's all about testosterone. I mean, I have energy now that I never had because I've been off for 6 months. And yes, my PSA, and yes, I track it every month. I think you should ask Ron or whatever, give you a standing order locally. Make sure you get a PSA every month and ask if they can check your testosterone every month as well. So you have a running record of that. Right now, it's probably 0 if you've been on for a year. I don't know whether you have a record of testosterone back the last time you were on a holiday or not.
Yes, I tracked the testosterone a little bit. The last one was, I believe, was up to 9. It's been 7, 8, and 9. I think the last one was 9.
Yeah, that's enough to wipe out all your energy for sure. You need to get up at least 200 level or 150 level before you start feeling a little perkier. The last time when you were off for 2 years, did your testosterone come back?
I don't believe I had it checked at that time, so I don't remember how far up it went.
Yeah, just start asking for monthly blood work, testosterone, PSA, blood work, and testosterone, and they'll do it for you. And just keep track of everything. And that way, if you doubling time and everything, if there's any activity, if you choose to get out, be able to keep track of it. And I wouldn't be too worried about the.
Okay, you're breaking up.
Without you noticing it.
You're breaking up quite a bit, but on 6/16 of 2015, the testosterone was up to 357.
Good. That's good that it came back. So you know that the last time it came back, so you have a good chance of it coming back if you go on intermittent again and take a break. But talk to them, about monitoring regularly so you can keep track of this and graph your PSA and just make sure that that it's not doubling, even at a low number. Of less than 1, just keep watching it and make sure it's not doubling every month or 2.
Yeah, in the past, it's always doubled. Once it gets loose, the doubling time is 6 weeks. That's been measured several times.
Right.
The concern I had, or one of them, it seems like my lack of endurance is a lot worse than anybody else. I got almost no other problems with Lupron, but it seems to be going overboard with my lack of endurance. I don't know if that's just difference in individual.
Dr. Wasasu, would you like to talk to Les a little bit?
Okay, I'm turning my mic and camera on. So I mean, considering you said you can't walk 120 meters, I'll believe you, and I'm sorry. This is a terrible situation. But have you attempted any exercise, even a 10-minute walk on level ground? What was your exercise over the last couple of years? because what has been shown is that with fatigue, I know several of the guys on the call here are very athletic and committed to being athletes as such, but any level of activity should help gain you some activity capable of having it. You don't have bone, muscle, joint, and circular problems.
Right. I would not call myself an athlete by any means, but the wife and I normally go to the YMCA to work out 3 times a week. We did not, we went back today, but we missed 2 days last week because we both had colds, but normally we go 3 times a week. It's not an excessive workout because my endurance is low, but I do whatever I can. And same way with working around home, I work until I drop.
Did you build up a sweat?
No, I never built up a sweat.
Well, all right. So assuming the doctor said you can exercise, I'm glad to hear you're going to the gym, but you might try pushing a little bit harder. I mean, it assumes again that your bones can handle it, your cardiovascular system meets the doctor's approval for an exercise.
Well, I had asked the doctor about that, how far I should push it, and by my description, he said, I think that's about the limit.
Okay. I'm sorry. I don't have an answer.
Have you done when you went to see the stress test, Liz?
I'm sorry, you're breaking up. Can you try that again?
Did you do a stress test when you went to see the cardiovascular
No, that's one
doctor?
test that he did not do. He said they would if they thought it was necessary, but the test that he had done, he said he didn't think it would show anything, so he did not do it.
Well, you see, I mean, I'm certainly not a cardio doctor, but when somebody complains of fatigue, then it seems to me that the stress test is probably the best thing to do, because then they can see at what point you do get overly fatigued and how much energy you do have. And you know, that's something that I would and then of course the other thing that we do know is that Lupron is associated with metabolic syndrome, and me, but you know, there are some connections here, and I don't know, if I were a cardio doc, I knew you'd been on Lupron, I probably would be doing the stress test, but I'm not a doc, and that's not medical advice. It's just what I think. Richard, what would you say about that?
Turn my mic back on. Sorry for the delay. Stress test will certainly show if you start to get chest pain and angina that you have obstruction to the blood supply to the heart itself. And that's the classic case for doing it is if someone has chest pain, we want to see whether there's actual potential for a myocardial infarct or heart attack from some sign that might be angina. It certainly could be something you can ask for. The lack of energy here, I think Len's view is to explore intermittent as a possibility. Certainly a cardiac workup certainly is an incredible thing to do. Working with a trainer, when you go to the gym with your wife, and you could have somebody who can coach you and encourage you. So sometimes it helps a lot to have somebody there to be a witness to your activities. We are a social species, and we tend to perform more rigorously and effectively when we have an audience. That's not something that's what I could prove from documented reference to the medical literature. I just speak about myself, and that is I exercise with a group of prostate cancer patients, and we are. I think we work better when there's a larger group there. If there's only 2 or 3 of us, we're not so good. If there's 8 or 10 of us, we're better. So these are that's the latter one is a sort of a psychosocial intervention. But if you are not moving, the longer you're inactive, the more difficult it is to be active. And the reason I asked about sweating is that one of the easiest heuristics or measures of whether you're getting enough activity or not is if you sweated 3 times a week, you're probably in the right range. I mean, if you're getting that 150 minutes a week, and you're not there. I mean, you're obviously challenged right now, and it's I know Sarah here. It's sad. By the way, your BMI, how are you doing in terms of weight management?
As far as what?
How is your weight management? How are you doing in terms of body mass index?
Oh, it was right borderline. It was just a hair over into the overweight category. Otherwise, it's
okay. So that's one of the signs towards what what we call metabolic syndrome. But you've already, the blood work presumably showed that you're not at risk in that regard. But I would say anything you can do to get the exercise up would probably be helpful in terms of reducing the fatigue in the long run. Now, granted, if you come off the exercise gym floor and you're exhausted, that's not what we're talking about. We're talking about when you'll feel more energized a day and a half or two later. And that's what you're exercising for, is the recovery tends to increase your ability for further exercise. And I'm going to turn it back over to Rick because this is more his territory. He's more an athlete than I am.
Well, in that category, what you had mentioned earlier about chest pains and so forth, that was one of the things that the doctor had asked me about. And no, I never experienced any chest pains or anything while I was, even when I was exercising or doing something to the point of being completely exhausted at home when I was working, that I never experienced any chest pain. It's just I was so weak I had to just essentially crawl to a chair in order to sit down and rest for a while.
We just thought of one other thing. That is, there is, for cancer patients, there is a sort of a suite of things: depression, insomnia, and fatigue. And they often come together as a triad. And you look at that together. And you might want to talk to your GP and your partner. If depression is a problem, it's probably very difficult for most of us to get off the couch if we feel just depressed about life. Well, that may be something you can talk to doctors about, because there's things that can be done about that as well.
Well, if you want to talk to my wife about such things, about getting off the couch, she is kind of the opposite. That she doesn't think I should be working so hard. She's pressing me to, sit down and rest. She thinks I'm pushing myself too hard, but I keep doing it.
Okay. Well, the matter of fact that you're doing it.
What was the third? Depression, fatigue, and what was the third leg of the triad?
Insomnia, inability to sleep.
Insomnia, yeah.
Look up the three together.
Yeah.
A lot of literature on that.
Yeah.
Cancer.
Right, exactly. And Les, that's a really good point that Richard makes, because when you're on Lupron, you can wake up many times during the night and you don't even realize it. It can wake you up instantaneously, so you don't get good REM sleep. And that can be a real cause for the fatigue. And, it's something that you should be able, I know that in the past, one of the problems has been that Quan has said to you, he can't really help you with your side effects. That was a comment that bothered me. I made a note of it. But you need a doctor who's going to work with you on the side effects of the treatments that they're prescribing. And if Quan's prescribing the hormone therapy, he should be responsible for the side effects of the hormone therapy. And I don't know who to recommend that you talk to about that other than your GP, but sleep may be an issue. The other thing that occurs to me, and you said you didn't have the results, and very typical, is that you could well be very anemic. And you need to look at your red blood count, because after 18 months on hormone therapy and two years on it originally, you could be compromised. And that also is very common.
My family doctor said I was not anemic, that he looked at the stuff. And as far as the sleep issue, when you have to get up about every hour during the night and go to the bathroom, you don't get REM sleep.
Well, but there you have it. You see now that there you have it. We're just learning that you're getting up every hour. So what I think you need to be doing is talking to Kwan or the urologist about getting you some drugs that are going to relax your bladder and allow you to sleep better. Richard, what drugs are you familiar with that help?
Sorry.
Go ahead.
If you're having nocturia that is getting up to urinate multiple times in the night, and it's more than once or twice, and it's like every hour, then it's time to get back to a urologist to see whether you don't have tumors that are obstructing the outflow from your bladder. And
Exactly.
So it isn't just, there are drugs that can help, but there's also surgical intervention can help if that's what's going on. And that's certainly a major cause of fatigue. So Quan is not a urologist, as I recall.
Yes, he is.
Oh, he is a urologist.
He is a urologist, but he practices as a medical oncologist. But he is a urologist, and that, definitely be talking to him about that.
Sorry, I was over talking Rick there, but yeah, you should discuss that with him. The multiple times of being woken at night is very real, and we actually, this is preclinical stuff, but we've with a colleague who's now a professor in New Zealand, we published on the loss of REM sleep for androgen deprived rodents, and it doesn't deprive them of sleep, of REM sleep, which you need to be alert. So you need some more data, and you're seeing Quan, so certainly you can ask him for both whether additional cardiac workup and cardiac data is worthwhile, and whether a urinary outflow needs further assessment.
One thing that I've got a few friends that are about the same age, and they get up about the same number of times per night as I do. So I was assuming that it had nothing to do with Lupron. That was more a matter of age.
No, I'm not saying it's Lupron. I'm saying that it can be due to obstruction from tumors, right? Even if you had the prostate removed, it is possible that there can be residual prostate cancer up against the urethra that can grow to be a tumor and block outflow from the bladder. So this is why. And if you have other friends who are at this age, they can be dealing with benign prostatic hypertrophy. That's typical of us as an age. Or they could also be prostate cancer patients facing a greater problem like what you're facing, and I envision I will be in the near future, or at least distant, not near future. Anyway, I think there's a lot to be looked at.
Okay, I will talk to Dr. Kwan about that when I see him, and also see a local urologist. I can speak to him of it also.
Yeah, I think my thought from listening to all of this is that if you can nail the nocturia, the frequent peeing during the night, that you are going to feel a lot better and a lot stronger. Is there anybody on this call who has suffered from nocturia and who has resolved it? And let me start with that question. Is there anyone on the call who has?
Hey, Rick. Hi. So I've been struggling with this polyuria, nocturia, insomnia for a long time, even from before I was diagnosed with prostate cancer. And I wanted to say one thing. It doesn't mean that there's a tumor or an obstruction. I have a constricted bladder neck, which is a hereditary condition that, the bladder muscle keeps having to work harder and harder and swells and gets larger, and it gets more increasingly constricted, which means it's harder and harder. You're retaining more urine inside you, and you go more often. You have these frequency issues. I forgot what the drug they gave me was originally. It was pretty helpful. It sort of relaxes. It was a heart medicine that had this secondary effect of what? Flomax, sure. Flomax. And that helped me a lot, and I go on and off drugs. I'm like off and on, Ambien and clonazepam, and I'm sort of stuck at that place where that is a short-term solution. It ends up becoming a long-term problem. But I manage to, if I wake up at 2 or 3 in the morning, I manage to be able to take a half of an Ambien and get like 3-4 hours sleep, which is really important for me. So I may be still struggling, but I use drugs off and on to get that time. If I go 2 days with real insomnia, I take drugs and I get like one night. Just, I guess it's not perfect, but that's the way I've been living for the last 5 years and longer than that. And Lupron made it worse, and then the drugs made it better.
Thank you, Larry. Yeah, I mean, I think this is the key. There are a lot of drugs that are available today. There's some pretty fancy ones too, some newer ones that work maybe better. But Flomax is certainly a pretty basic one that you could consider. But I would suggest that you hit on this nocturia issue, because if we can solve that and we can see if that's what's causing your lack of sleep, and you feel stronger from that, that's going to be a big issue for you, Les.
Is Rapaflow in that same category?
Which one?
Rapaflow.
Rapaflow. I don't know. Rapaflow.
Scientific name. I'd have to see the scientific name. But yeah, there's a bunch of them. There's a bunch of drugs that can be used for.
Yeah, this is Bob Bordig. I've been taking terazocin for years, and it has definitely helped.
Yeah. Terazocin, I certainly have heard. His name I always forget. I've got it down somewhere, which is expensive but supposed to work really well.
Mirbetriq.
Yes, thank you. What's it called?
Mirbetriq.
Yeah, Mirbetriq. Mirbetriq is the fancy one that's supposed to work. There's a whole bunch, but I think that's where you got to hone in. Anyway, we have to move on because we've got 2 or 3 more people, but I think
Hey, Rick.
some good ideas. Yes, Len.
Yeah, I'm sorry. I just need to make sure I get this one other message across to Les based on our experience from our friends up in Toronto. Les, there was a guy there with prostate cancer who was doing a lot of intermittent therapy with hormone therapy, and he was feeling an incredible amount of fatigue. And long story short, he was almost passing out, and he went to a cardiologist, and turned out he had a prolonged QT interval, which is a cardiac arrhythmia, which could be caused by ADT. But in any case, it can be very serious. They gave him a pacemaker, and he did so much better after that. He had more energy, wasn't passing out. So I hate to do this to you, but I'd say get someone else on your team, a cardiologist. Just to rule that out. It's a serious enough condition that you want to know about it.
And I have one comment about the sleeping, Les. A lot of people find that melatonin is helpful. You can buy that over the counter. It's not a drug necessarily, but it helps a lot of people, rather than going to a sleeping pill like Ambien. First, try it anyway.
To me, the first step is you got to wrestle with the nocturia, because if you're getting woken up every hour because you need to pee, you've got to deal with that before you can deal with anything else. So, but yeah, and again, that Len raises a good issue that you need to raise with your with your cardiologist next time you see him. Anyway, we're gonna move on, and Bob Bordiga. We're gonna go Bob Bordiga, Jim. So Bob, why don't you tell us a little bit, tell the guys a little bit, remind them of your situation from.
Sure.
And where you are in your decision-making process.
Yeah, 4 weeks ago, I was diagnosed with prostate cancer in a couple of places. The worst is a Gleason 9, and then there's a 7 area, and then a couple of 6s, and I've been trying to make the one decision that they're leaving to me at the moment about the type of treatment, and neither one has been recommended more than the other. They tell me my chances are about the same with each one, and that's either surgery or radiation treatment. The radiation treatment we're talking about that we've been talking about is IMRT and IGRT, external beam radiation therapy, combined with Lupron, which is what they use at Kaiser. I'm part of the Kaiser group here in Southern California. I was supposed to have an Aximum test today. I showed up, and they didn't have the injection for me. They thought they ordered it, but the people they ordered it from said they didn't have a record of it, so had to reorder it. So it's going to be pushed back 1 week. I'm a little bit frustrated by that, to say the least, because I want to make a decision soon on what I'm going to do, because I feel like it may not have spread beyond the prostate yet, but it's got a fairly good likelihood that it will, so that the sooner I get to start treatment, the better. I have a question to see if you guys know about, and that is, if I choose radiation therapy, which I'm leaning towards, but I'm open, I'm completely open, and I'm interested in anything anybody has to say to help me make the decision. But having done a bone scan that's negative and a CT scan that's negative, don't know what the Aximum will show. But if it doesn't show a spread, if it's not known if it's spread to the lymph nodes or any place else, and I choose radiation, will my radiation plan treat areas outside my prostate if they don't know that it's there? That's my first question.
Is very definitely yes. The protocol for somebody with a high Gleason like you have is that they will for sure radiate. I say for sure. I think certainly at Kaiser and most docs will radiate the whole pelvic girdle. There are still some doctors that don't do that. They're few and far between. I think it's an error, personally. We don't give medical advice, but this was my experience. I had the whole pelvic girdle radiation for the Gleason 8. And I would be very surprised if a radiation oncologist did not want to radiate the whole pelvic girdle, then I'd be looking for another radiation oncologist.
Right.
I just want to add one thing. I gave Jake a little piece of advice, and I want to give it to you, but it's too little and too late, which is that it's always good before your Aximum to call and make sure that the dosage is on the way, because they send it out that day. And for Jake, it was for different reasons, but before you go in next time, you might want to check with them that the dose is on its way, it's en route to get to you.
Okay, good. Nice to know.
Okay.
Right, and then, so if anybody else has any thoughts about surgery versus radiation for me, my PSA is currently 29.8, and it was 21 a couple of months ago, and the reason that we had the biopsy was because of the jump. There's one other yes. Possible complication, which I don't necessarily think it is, but with the CAT scan, the CT scan picked up something in my thyroid, and there was a large nodule. We did an ultrasound a couple of days ago, and I'm being referred to endocrinology, and they think that maybe they want to do a biopsy of that. So I know that the axonome scan is going to show the thyroid, and I don't know if that what that means, or if that is an indication that the cancer could have spread already to the thyroid. But I just bring that into the mix.
Well, I am not aware of prostate cancer going to the thyroid. It would be in the 12 years I've been doing this, that would be a first. I mean, it could be totally unrelated in there, but I don't know that. I've never heard of it in soft tissue in the thyroid, but that doesn't mean it couldn't go there. But
okay, I'm not so worried about that. I looked into that a little bit, and it may not be anything, but.
I want to go to Richard Wasasu because he has some questions for you, and he may have some thoughts. Richard?
Okay, I see my mic is on. Can you hear me?
Yes.
I hear you.
No, I was just asking a few background things. Do you have a family history of prostate cancer, and how old are you?
I'm 70 years old, no family history, except I found out that a cousin on my mother's side had it.
Okay,
but other than that, I mean, I guess that's in my family, so yeah, that's about it. The only other cancer is on my father's side, a cousin on my father's side, is my maternal grandfather had colorectal cancer, but not prostate cancer.
So there's the big debate for patients like you, even if they find positive nodes on the axiom scan, is do we debulk the primary? If we know the cancer has spread, is there a reason? Is it worth treating the tumor, original tumor itself, the gland? And that's sort of growing evidence. I don't think the evidence is absolutely solid, but it's growing. That there's a case for if you have minimal amount of mets, but let's say the scans find that it has spread, but it hasn't spread very far. That could be a strong case for getting the primary treated. Now, when you mentioned surgery, are we talking about laparoscopic, robotic assisted laparoscopic?
I think probably robotic assisted laparoscopic is, I mean, my urologist can do it robotically or not robotically, has experience with both. But
how many has he done? How many robotic surgeries?
About 500, I think.
Good, that's what you're looking for. All right, now there's, in terms of the distribution of the tumor in the gland, have they had discussion with you about whether the surgery would be nerve sparing or not? Has he talked to you about
that? Could you say that again? It would be what?
So if the tumors are in the gland and they're up near the edge of the gland, the nerves to the erection or control erection.
Oh yeah, they think they can save one of the nerves.
Okay, that's what I was talking about. Nerve sparing. Okay, so that's positive stuff. The oxium scan to me sounds the perfectly reasonable thing to do. When you going back to radiation, you're only considering external beam. There was no discussion of brachytherapy.
We have talked about it, but with my BPH that I've had for many years, there was a greater risk of urinary issues. So I understand substantial additional risk. No. So it wasn't as recommended to combine the types of therapy, but to do brachy alone, there's a possibility of doing it high dose brachy, and we're talking about that a little bit. But from the studies that I've seen and the information that I have, it's more recommended for intermediate risk than high risk. So I'm
maybe a candidate for what do we
and they want to do a urine flow study on me, which I'm going to have done in 2 days to see if I'm a good candidate. That'll be also help them figure that out.
That's perfect. That's what they should be doing, to the best of my knowledge. And I am also not an MD. I mean, I'm a research scientist, but I'm not an MD. So please don't misconstrue that. Sounds to me like you got good options. Sounds like you're getting good advice. And if you're frustrated, as most patients are, trying to make a critical decision between surgery and radiation, the fact is that we would need data, as I usually phrase this, for 15 or 20 years to know for sure that by then the radiation surgical procedures will have changed. If one was a clear favorite over the other, absolutely, we would know that already. And basically, it's comes down to almost individual choice. There is not, it's not like anybody's hiding information from you.
No, I'm aware. I mean, I'm more feeling now that either choice is a good choice as long as I make a choice, and we do something, so I'm just trying to get as much more information as I can, but I really want to decide the next couple of weeks and get started. My other question, I have one more question about it, also, well, two more, unfortunately. One of them is, suppose I asked to start on the Lupron right away. I know that I know that I need to have it for when I'm going to do radiation, but if I do surgery, I've read a couple of things where you could have more negative side effects if you combine it with surgery, if you do it before surgery. But I feel like, that would at least be doing something now. And I'm not so sure about that. The other thing that I heard about, and you talked about it tonight some, is about genetic testing, and I was wondering whether that might be something that worth looking into for me.
So let me answer a few things here. It's not a bad idea to start Lupron because it will stay the disease. At the same time, if you're going to get into treatment within the next 3 or 4 weeks, it probably doesn't really matter if you wait. And some surgeons don't like you to take Lupron before because they feel that it can affect the surgery. I'm not really sure why, because it would make your prostate smaller, but there are some docs.
Yeah, I've read that too.
Peter, who I'm sure will chip in a moment, did 8 months of Lupron before he had surgery. The second point I want to make is that for you, surgery is of marginal benefit, because the likelihood is that you're going to have to do the radiation and the hormone therapy anyway. And I think the issue, as we've talked about, is what is that marginal benefit, and is it worth going through a whole bunch of additional side effects for whatever that marginal benefit is? And the numbers that I've always seen is 3 to 4%. And that came from Peter Carroll at UCSF, and it's very hard to get doctors to give you a number. Most doctors don't want to give you that number. He did. We've often asked, but we haven't always gotten the answer. The other thing I wanted to address was the genetic testing, and the fact that you have colorectal cancer in your family and you have prostate cancer, it's possible that you may have a mutation that Peter had, which is a Lynch syndrome mutation. I'm going to ask Peter I forget which one it is, MLH8, I think, but Peter will tell you momentarily. And that's an easy test. We suggest, to make it really easy, you can do it yourself through color.com. It's $250. The panel's big enough. If you want to do it through Kaiser, you can. They should be willing to do it for you, given your history. But it's going to take longer, be more complicated, even though they'll cover it, because they have a whole program where you have to go through genetic counseling.
Right. What is the website you said? How can you spell it?
Color.com.
Oh, Color, C-O-L-O-R.
C-O-L-O-R. But then there's a second one, which I'll tell you right now, which is just the cancer test, but I think it's the same price. It used to be a little cheaper, but now that I think they're priced at the same. So I think they're both $256 when I looked recently. But that test is cancer plus it's a heart test. But they don't tell you they have a separate test, but I think they've brought them into line. but I'll look for it. And are you? I'll put it in the chat window. I'll send you a chat window. Peter, why don't you talk a little bit about Lupron before surgery, and also the test that you did and the mutation they found.
Yeah, Bob.
Yeah.
I had urinary retention issues, so that's why I wanted to do radiation, but the radiation people wouldn't go near me because I was on a catheter. So I had to do surgery first, and I don't know what your Gleason's. Are you high Gleason?
9. Gleason 9.
9. Okay, so am I. So I started Lucidex right off the bat, right after my to buy me time. Decided what to do, and it took me 8 months to decide to to make an appointment and actually do radiation. I mean, do surgery. So and I was happy for it. I had the result. I went to an excellent doctor. I came out of surgery continent, had incontinence problem. I too had so-called one nerve sparing, but it's rare that you're going to get erectile function even with one.
Yeah, I'm okay with
one
that.
nerve. It's unlikely you'll get erectile function. And then I made it 11 months after my surgery, and then I had to go for radiation afterwards. So I did it in that order, and since then I've had some other issues, but yeah, I did a genetic test about a year and a half into the thing. I went through UCSF, their genetic counselor, and they picked up Lynch syndrome because I had some colorectal cancer in my family, but I had a father with prostate cancer. And there's a lot of data. The gene mutation I had, of the 12% of guys with genetic mutations, 12%, only 1% of that 12% have the genetic mutation I have. So it's pretty rare, but it does signal a propensity toward rectal cancer. So I have to keep an eye on that.
Yeah.
It's worth getting the genetic. I mean, it's a simple test, just a mouth swab. Go to a place, make sure you use a place that does a pretty good number of genes so that they can give you good results. But it's pretty non-invasive. Where at Kaiser are you getting treated? Sounds like
in Los Angeles, Sunset Boulevard offices mostly. Yeah.
Good. I had a urodynamic test at Tower Urology down in Beverly Hills. What's his name? Gary Leach, the urologist. And I was very happy with that result too. The UCSF was scaring me, telling me I had cancer, and that's why I couldn't urinate. I was having urinary issues, but
yeah.
Tower Urology, my bladder was fine, and it was essentially the tumor that was blocking my my urine flow. And since my surgery 5 years ago, I've been fine.
Right. But if I have a test done outside of Kaiser and I bring it to them, they'll take it seriously. They won't say, "Well, we got to do our own test," right?
I mean, I'm sure if you take them a color test, they'll take it. They'll take it seriously. Yeah.
Okay.
Yeah.
Okay.
Thank you so much.
I would just go for that color test right now. Like I say, there was one that was $50-$60 cheaper, but it looks like they put their pricing into line. So it doesn't matter which one you do anymore. They're pretty much the same. Peter, what about the issues around Lupron prior to surgery? Do you know anything about that?
I had to stop it before surgery. So I was on for about 8 months, and then I was off for 11 months. Then I went back on, et cetera, et cetera. But I had no problem doing Lupron and Casodex before surgery. Didn't seem to affect anything. Peter Carroll didn't seem to have an issue with it. He just said stop it before surgery.
Okay.
Good to know.
Okay. Okay.
Yeah, Rick, I just
yes,
wanted
Carl.
to add. I just wanted to add because I was on the phone with my insurance company once again today about the Aximum PET scan that I had several months ago. They had paid for the PET scan, but not for the Aximum, and I got a bill for $5,000 from the radiology office, which I have had to pay, and still waiting with the insurance company to see. The problem was that when I originally had the PET scan, my oncologist had a peer-to-peer review with the insurance company, and they got the PET scan approved, but they never had a discussion about the Aximum. So the Aximum did not have pre-approval, and that's why I'm stuck right now.
Yeah, I mean, I still don't get that because Aximin is an FDA-approved test, and you're now on Medicare, right?
Not yet, not yet. 6 months ago.
Yeah. Well, I just think I don't know what to say. We've talked about it before, but that's not an issue. That's not an issue for Bob because he's at Kaiser Permanente, so it's an HMO. But yeah, thank you for raising that. I have put a link to the color cancer genetic test in the chat window, Bob.
Yeah, I'm on the site right now.
Okay. All right. Well, we're going to move on because we've still got to visit with Jim Ward and we've got to visit with Jake. So, Jim, how about you updating us on where you are with your treatment?
Sure. It probably will be a pretty brief one. So I'm set to begin radiation therapy on July 9th. That'll be the first treatment of, that'll run 8 weeks. So I'm just on the cusp of moving forward with that. So I kind of what the other caller said, it's kind of just got to move forward with some path, and I feel like I'm making the right decision for me. As far as the only other real update that I have is, I'm right at I'm right at about 6 months of being on Lupron, and about 3 months of being on Zytiga, and the last PSA that I got went from 0.94 to 0.45, which is good. But I thought I might just put it out there for people for comment. My testosterone went from an initial, I guess this is before I started the ADT. Back in late December, it was 238, and then roughly every month since then it's gone 15, 17, 22, 25, and then most recently 33. So it's kind of gradually trending up, and I don't know whether that means anything when considering that the PSA has continued to trend down. So that's really all I have, guys.
Mm-hmm. Well, that's kind of interesting, and I think it's worthy of review that testosterone number with your doc at KU, if not him, certainly with Paul Korn. You may be a candidate to switch from Lupron to Firmagon, because it may be it works slightly different way, and it might be more effective for somebody like you. And I think that if I saw that trend going from when was it 12? In what month was it 12, or how long ago was it 12?
It was 12. Excuse me. It was 15 in February, about a month after I started the Lupron. So it had gone down from 238 in late December to 15 as of mid-February, and then you could more or less go out, a month each month after that. It went from 15 to 17, 22, 25, and then most recently, just at the end of June, it was at 33. So,
Well, I mean, that's Lupron is controlling your testosterone. I don't know, especially since you're on Zytiga as well. So I'd be asking the questions if it were me, and that would be a red flag. Nail it early. See what happens when you switch to a different LHRH, either an anti-androgen like Firmagon, or even another LHRH like Eligard or Zoladex and C. Who else has a comment on that?
Yeah, Rick, I'm shocked to hear that being on Lupron plus Zytiga, that his testosterone levels are still fluctuating up into the 20s and 30s. I've never heard of that before. I think most guys experience single-digit T levels when they're on Zytiga. That's puzzling.
I've been on Lupron for 7 years and Xtandi for the last 2, and my testosterone never went below 20.
Yeah, but that's Xtandi blocks the testosterone receptor, but Zytiga blocks the synthesis of testosterone. So it does a much better job of crushing the T levels.
Okay. But even on the Lupron, when it was working and keeping my PSA low, my testosterone never went. It was always, and it did fluctuate 20, 25, 30. It always stayed below 50, but that's, stayed castrated, but not just barely.
That's not uncommon. On Lupron, that's not uncommon at all to have your T levels 20, 30, even higher. Okay. But it is something I've never heard of with Zytiga before.
Zytiga, okay.
Yeah. So, I think, Jim, it's not an alarm, but it's certainly something that should be raised with your medical team as to whether they want to experiment with some different drugs for you.
Okay. I guess it's not so much the Zytiga we're talking about, but experimenting with the other.
Yeah. Well, that would be my first thought. But and the other anti-androgens don't work testosterone in the same way as Len just mentioned. But I think it's just an issue to bring up. And the first thing I think somebody would probably do is try you on a different one and see if that makes a change. And it can do. We've known many guys that it makes a change for.
Okay, well, I appreciate it. No, I will definitely. I'm going to raise it with the team, and including Dr. Korn, and see what they have to say.
Yeah, I mean, I think it's smart. There was something else that was on my mind I was going to ask you about, but basically you're going to be starting this IMRT July 9th, correct? And
that's right.
And you have 45 sessions?
Yeah, it's 40 something. Yeah, I don't remember exactly.
Right. Have they put in the fiduciaries yet?
No, my radiology oncologist you know, if you're talking like about the little gold seeds, he does a CT scan every day.
That's what they do.
That's it.
So they're not going to use gold seeds. They're not.
No,
That's a lot of
he
radiation.
uses a.
That's a
That's
lot of
old
radiation
equipment.
for 40.
I mean, the only thing I can say to you, Jim, and this I do feel strongly about, it's old equipment, and they shouldn't be doing that anymore. I mean, it should be guided therapy, either with the calypso markers or with the fiduciary markers, so that the machine responds during the radiation. The fact is that they can change this, and I do feel really strongly about this. If it were me, I would not go there unless I was doing today image-guided radiotherapy, certainly for the prostate. And you know, you talked to me way back when we talked on this call about the difference between getting radiation in Kansas and getting it in other places. But getting radiation without image-guided equipment today is not the standard of care. I mean, anybody else want to, am I wrong? Does anybody else?
This is Bob. This is exactly what they're doing for me. If I choose radiation, they're going to do IMRT and IGRT, and the first thing they do is put in 3 gold markers.
Right. I mean, what they're doing for you is, they weren't doing that 10 years ago. I don't get it.
You're talking about the daily CT scans?
Right. And let me, you know, here's the problem. If you move on that table, to keep you still on the table, how do they stop you from moving on the table?
Oh, they did the mold.
The mold. And they probably put a couple, and they did say they did, and they did a couple of tattoos, right? Some dots.
Yeah, that's correct.
Right. This is ancient. This is ancient technology. It's not how they do it today. And if your doc is still doing it that way, he's not the right radonc. In my opinion, he would not be my radonc, and I ask anybody. And I bet dollars to donuts they would not. This is, you need to somebody who's doing IGRT, image-guided radiation, where either with the fiduciaries that Tom mentions, which most of us have inside of us, certainly those of us who have done radiation, or the Calypso machine, where they put in little transponders, which actually moves constantly right the way through. It moves with your breathing. It adjusts breathing. But they can't adjust with a CT, and you know, I don't want an effect from the from the radiation. Who else?
You lost what you said, Rick. You broke up there.
Okay, I don't know what you heard and what you didn't hear. But
about moving with the fiduciaries.
Okay, so the fiduciaries, if you have either the gold fiduciary placed inside of you, then the equipment moves with you.
Right.
In virtual time. It's
Right.
moving the whole time, right?
Right.
I don't think there's a guy on this call who do a mold and tattoos and a daily CT. They would not do that today. That is old technology. And my concern is that you'll come back to us with that you would not have had you done image-guided radiation on the prostate part. You know, I think it's possible that you can do it that way for the pelvic girdle. I don't know enough with the pelvic girdle, but let me throw it open. Who would like to?
I think they commonly use that kind of radiation for other things besides prostate cancer. But with prostate cancer, you have the advantage of being able to reach up and install the gold markers. It's a simple thing to do, and that's why they can do it that way. When I had proton radiation last year, they used the CT scan because they couldn't install gold markers because it was in the abdomen. But so they're probably using that kind of technology, but they probably don't do a lot of prostate work. I would ask how much prostate work the radiation oncologists actually do.
Anybody else have? Has anybody here had radiation for their prostate, primary radiation, where they have not had some type of a mark implanted?
I had the same, this is Les, I had the same as what the gentleman Jim just illustrated. Sounded the same as what I had.
And when was that?
6 years ago.
6 years ago. And where was that?
Moline, Illinois.
Right. So I think that if you go to a community radiation oncologist, you might get that. I don't think you're going to get it at any center of excellence. And if it was me personally, I would not do it.
I'm just curious, Len. I know you had it done. Did you have the markers, or what did you do?
Yes, I did have the gold fiducial markers, and I agree with Rick that you should not have your radiation done there if they haven't done that. Is it possible, Jim, that they did do it and somehow you didn't know they were doing it, or they just didn't tell you? Why don't you clarify that with them first? And if they have not done that, then go somewhere else.
Well, okay, I think I can answer that question. I mean, I assume that they insert those markers through coming up through the rectum, right?
Correct.
Yes.
Yeah, like when they took the initial biopsies, okay? I can assure you they haven't done that. I mean, right. I went in for a simulation session, and about a week ago, and that was it. I mean, I laid down on the machine, and it kind of moved around a little bit, and I don't even frankly know what they were doing, but I assumed it was like doing a CT scan or an initial CT, and then they did those tattoo markers.
Right.
Am I the only one concerned about 20, 30, or 40 CT scans and the excess radiation from that?
Well, there's that too, yeah.
No, they're very low dose CT scans. I had that done also when I had my IMRT. It's not like a regular CT scan.
Okay.
I think the bigger issue is that type of equipment in order to be able to follow them. Either an equipment that adjusts, triangulates on the 3 gold fiduciaries, or equipment that responds to the radio wave that's emitted by the. And if they don't have that equipment, they can't do it, and they may not have that equipment. If they don't have that equipment, they're out of date. And
You
Go
broke
ahead.
up on that last part. So you talked about the equipment that, can triangulate on the gold seeds, and then you said something else, but it broke up.
Okay, so they have equipment that triangulates on the gold, or they have equipment that responds to the transponder signal. So the transponders are like what you go through, to pay your toll at the on the freeway. It emits a signal and registers in the transponder, and that's how the Calypso machine works.
Rick,
And yeah,
I think, I could be wrong, but I think the only place that does Calypso with those transponders is a Cleveland Clinic. I'm not aware of anybody else that does that.
oh, no. They do them. They do them all across the country, Len.
Yeah. Okay.
If you Google Calypso radiate Calypso, I'm just looking. North Kansas City uses the Calypso system.
Okay.
So you'd have to find a radiation oncologist that uses the Calypso system. The other thing, let me Google IGRT. IGRT Kansas City. Kansas City is right, correct, Jim? You're in Kansas City?
Yes. Yes.
Okay, so well, it says University of Kansas does IGRT. So I don't know why they're not giving you. If they do IGRT, that's what you would. So you can talk to them and say, no, I absolutely would. Image guided.
I mean, I guess it raises the question. I don't know how to articulate the question or how to phrase the question, but what machine are we using here?
That's right. That's the question.
I mean, but again, I don't know that the answer is going to mean anything to me.
Oh, this is Bob. I can tell you what kind of machine they're using here at Kaiser, Southern California, where they're putting in the gold markers. It's called a VMAT, V-MAT.
Yeah, I think that's a variant. Who's a manufacturer?
That's all I know. That's what I wrote down from the consult I had.
Yeah. But again, they have varying machines at. It looks like we just lost Jim. Are you there, Jim? No, he'll probably dial back in. Anyway, I think he's got the message. He'll dial back in. Let's touch base quickly with Jake, and then when Jim comes back, we can finish the conversation.
I can't pull a Joe Biden and say my time is up.
Nope.
Well, briefly. First of all, my PSA almost doubled. It went from 8.8 to 14.6 in less than a month, 66%. Doubling time of one month and 1.37 months. I'm still waiting to get my abiraterone approved. Yeah, I think Jim just came back. Are you back on the line?
I did. Sorry, call got dropped. So I don't know where we were at.
Are you done with him, Rick, or were you?
Well, let's just tie up the loose ends, Jim. I mean, I think you got the message. I know I come on strong, but it's not just me saying this. I mean, they just don't use this. They do, but whenever we hear about people doing a mold and tattoos and etc., we tell them that's not the right place.
Well, Rick, when I had my radiation at MSK, okay, it was 5 years ago. I don't know if you consider that ancient history, but I had the gold fiducials, but I also had the mold and the tattoos.
Well, yeah, but I mean, I didn't have the mold, but the fact is that I had the tattoos. But the fact is that you had the fiduciaries, and that means that the equipment was correct. It isn't the issue about the mold and the tattoos. It's the lack of the fiduciaries.
Right.
How are they doing guided? If they don't have, how do they do guided if they don't have that in there?
Right. Yeah, I agree with you. So Jim, you just need to ask them, why haven't you inserted the 3 gold markers in my prostate to guide the radiation? Just, that's it. That's all you have to ask them.
I think, well, I think the answer is going to be that I think I've kind of gotten that answer, which is that's not what I do. I do the daily CT scan. I mean, I hate to be that flippant about it or that glib about it, but that's the answer I got, and it wasn't very satisfactory. But you know, I just don't know what to do with it.
Walk away.
Ask them if there's an option to have the gold markers inserted.
Look, if you go radiation oncology treatment options, they list image-guided radiation.
Yeah, I'm looking at it. I'm looking at it. Yeah.
Now, if they do image-guided radiation, you know, I think what they're going to say to you is that they're image-guided, that they do it, they say such as computed tomography scanning to deliver IMRT daily. So if that's how they guide it, you have to ask them, well, what happens on the table? Because my organs can move on the table. And that's why you have these fiduciaries implanted. So the equipment isn't guided by the morning CT scan, it's guided by what's inside you, and it can adjust every few seconds, or in the case of the Calypso, it can adjust instantaneously. And that's the sort of image, that's the sort of image guided that you want. And if they don't do it, I suggest you go to somebody who does either Calypso or inserts the fiduciaries. That's what I would do.
Well, and here's the thing, Rick. I mean, I'm looking at their radiation oncology page, which I think that's what you're looking at.
Yeah.
And they mentioned Calypso localization system.
Where do they say that? Under where?
Radiation treatment options.
Yeah. Under which? The one that I'm looking at says treatment options. Stereotactic radiosurgery, intensity modulated radiation, brachytherapy, TrueBeam. So we can't take the time right now.
Yeah, I know.
You know, and you've just got to get onto the computer with us so that we can send you these. So we can. This is why we keep saying to you, you've got to use the computer to join so we can show you the same, make sure we're on the same links. But, you know, I think the bottom line here is that you need either the Calypso system or the gold fiduciary. Well, I don't want to say you need, I'm not going to give you the advice. I'm going to tell you that if it were me, and I think if it was anybody else on this call right now, that's what they'd be doing. Okay? And you can call me, or you can call Len. Okay, but you've got to get on the stick on this. I would not start this with somebody that isn't using the most up-to-date technology.
All right, guys. Thank you.
Okay. Okay. So let's just flip back finally. Just gave us Mr. Hannum. So you're telling us that your PSA is now what, 14 point what?
14.6. went up from 8.8 in May to 14.6 in June.
Okay. And the first step that your doc is suggesting is for you to use abiraterone, and you're still waiting for that to get approved, correct?
That's right. Yes. They're talking about generic Zytiga. I don't know what the holdup is. I don't know if it's the insurance or the a miscommunication of the frequency. But anyway, yeah. So they're working on it. I'm going to keep on them about that. I also
yeah.
We had a few questions last week. Somebody asked why they didn't compare the old scan from 2012 to the new scan, and I finally got an answer. They said because they're two different technologies, FDG versus Axumin. They said they really weren't comparable. Plus, they're 7 years old, so that kind of makes sense. That's what they said.
I know that's what they said, and we said that's what they would say on this call. And what we said to you is, then at least please tell me how has the same lesion changed in size?
All right. Well,
they can match the lesions.
It's like pulling an hen's teeth, Rick. I mean, it's just, I can't call the radiologist directly. They only go through the oncologist, and the oncologist gets a hair up her butt. So I was lucky to get that answer out of her.
Well, okay. I don't want to get upset, but it's your life and not hers. And if you can't say to her, I know it's different technology. All I want to know is the tumor that they saw in 2012 larger or smaller than the one they see today? Given, and I understand it's different technology. It's just laziness.
Well,
it's laziness.
The radiologist notwithstanding, she wants me to come in, or when I come in the next time in July, we're going to compare the two CDs. So she'll be able to tell me whether they're smaller, bigger, whatever.
Okay, but that's what the radiologist's job is.
I hear you, Rick. What can I say?
But you can tell her that you're really unhappy about it.
I did.
To be done, and do you put it in writing?
Well, I did.
You put it in writing?
I did. I put it in writing. You saw what I wrote.
Yeah, but that was before you got an answer. I mean, here's what I would do now, Jake. I would say I understand that the technologies are different, so we cannot do a strict comparison. However, I would like you or the radiologist to look at my lesions from 2012 and whatever you see from 2019, and to tell me whether the lesions that appear in both scans are larger or smaller in writing. I guarantee if you do that, you'll get a response, because that then is written, it's in your record, and it's a specific request that can be done.
Okay.
Maybe devil's advocate here, Rick. What good will that do him anyway? What if they say they're bigger, they're smaller? What does it matter?
It satisfies Jake's peace of mind, which he needs, because he's telling me he doesn't know. He doesn't know if he's worse. He doesn't know if he's better. He doesn't know. We don't know to what extent the treatment has really worked. I mean, are those lesions that were there 7 years ago way bigger now, or are they smaller? So we had some success. That's all. I mean, it's not going to change. The treatment options could be affected, but with Jake, they're probably not going to be affected. But the fact is that it's something that he's entitled to, a comparison of scans to tell him where he's at.
That's what we're going to do. She's going to compare the two CDs, and we'll talk about them. She did say last time, she was even with the new Mets, she was, she was kind of happy with the scan because she said that the old ones had been encapsulated, is the way she put it. She said it was scarring, and she called it, and she used the term scarring and encapsulated. So, and I want to get a clarification on that because I'm not quite sure what that means, and that's why I need to meet with her. And finally, I know we're running very late, but the final thing is they're going to submit for me for a foundation liquid biopsy.
Okay, well that's good.
The foundation won't talk to me as a patient either. They'll talk to me, but it has to be submitted through the doctor. So, and I talked to the receptionist today. She's going to do that. So,
What do you mean foundation won't talk to you?
well,
You wanna know?
they won't accept the request from me. It has to come through the doctor.
Sure. Yeah, that's true.
They talked to me. They answered my questions. They told me it was $5,000. But they said I had to submit the request to my doctor, and then they'll send a kit to her, of course. So,
That's covered, isn't that covered by Medicare?
I believe it is, yeah. I hope it better be.
It is.
Medicare won't cover it unless the doctor requests it.
Okay. It's got to be requested. The issue is our Foundation Medicine answering all your questions? Do you have any unanswered questions from Foundation Medicine?
Not at this point, no.
Did you ask them about the $5,000 cost?
Yeah, I told them what I had heard a year or so ago, that if the insurance didn't cover the cost of the biopsy, that they would eat it. Well, apparently that's not the case. But then you said last week that you could intervene on my behalf if it becomes an issue. And like Len says, hopefully it'll be all covered by between my Medicare and my secondary. Hopefully it will not be an issue.
Did they ask you what sort of insurance you had?
Foundation Medicine didn't know, but that'll be part of the approval process or the application process.
So Foundation Medicine gave you a price without asking you what sort of insurance you have.
Correct.
Did Foundation Medicine ask you if you're on Medicare?
No, we didn't talk about insurance at all.
Right, I will take care of that. I'll take care of that with David tomorrow. Because they should not be giving.
Have you ever done chemo, or have you just been on hormone treatment?
Just hormone treatment and Xtandi, Peter. No chemo.
Well, that's interesting. Well, it would be interesting to see what they say about differences in tumor, because I'm not. It's a good question. I don't know whether hormone treatment or second line actually shrinks tumors or not. Or whether it just holds things in check. So I've always wondered that. Whether is it actually treatment? Is it just buying time?
My understanding is it just buys time. It's not curing it. It's not gonna resolve any any mets. I don't think.
No, Peter, I had hormone therapy after my first imaging of lymph nodes, and then something like 6 months later, after being on Firmagon, I was imaged again, and the lymph node size had shrunk by half. Is that what you were asking?
That's interesting. Yes, that's interesting.
At that point, I had no other therapy.
Interesting.
Well, I know that my cancer's spreading, obviously, because my PSA has gone up almost doubled. New meds, so whether the old ones are there or not, I don't think is really relevant anymore. I've got more to deal with. So whatever I get is going to be systemic. I have too many Mets for radiation. Even though I might be able to get some in my shoulder, my scapula, or maybe to my cervical if it's not too close to my heart. And that's what I'm going to talk to my oncologist about when I see her on at the end of July.
Yeah, but the only reason you would get that is if they're troubling you. Are they troubling you?
Well, you know what? I don't know if it's psychosomatic or not, but ever since I found out I had some in my shoulder, I've been waking up with arm pain. And I don't know if I think it might be psychosomatic.
Okay. So to request, you have too many Mets for the spot radiation to be a treatment option. So the only use for you for the radiation at this point is palliative.
Right.
So if you have pain from any of the places, it makes sense to talk to her about your clavicle, your scapula, the this, the that, the other, because you think it will restrain the cancer, is a non-starter.
Oh, okay. It's not going to do any good. It's not going to do any good unless I get start having pain, and then possibly then it would.
It's not going to help you manage the cancer.
Okay.
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 It isn't that it isn't going to do any good, but it's added radiation, and you don't like radiation. You don't want radiation anyway. You're concerned about CT scans.
Right.
So there's no point in putting radiation into your body if it doesn't serve a purpose. And it doesn't serve a purpose when you have as many Mets as you have, unless those Mets are causing you pain, in which case it can palliate the pain.
Right. Okay. Well, that makes perfect sense. I'm sure
Len,
she'll.
would you agree with that, Len?
Absolutely, yes.
And I'm sure she'll tell me that when I talk to her.
Peter, what do you say?
Oh, he just left.
He just left, yeah. They're dropping like flies. We went from 14 callers to 6.
So we're about a half hour over.
Yeah. So anyway, that's my story for right now.
We weren't expecting Jim Ward to drop that bomb on us, so that's what threw us.
Sorry, guys.
Oh, you're still there. That's okay. You're very welcome. So that's what threw my timing, to be honest. But Jake, here's what it's important. A couple of things are important. One is that we try and get some sequencing done. Here's my concern, and this is what I don't know. And this is what if it were me, I'd be calling Foundation Medicine tomorrow. I don't know to what extent the liquid biopsy is covered. What is covered in Medicare is the tissue biopsy.
Oh.
Okay. So you've got to talk to, and I will talk to David Marshak in the morning, and we'll see what we can get done. But I don't think that the liquid biopsy is part of the Medicare coverage.
Oh, that's
okay. And so if you ask them about the liquid biopsy, that's probably why they didn't ask you about Medicare. And it's going to be at the discretion of your insurance company, and your oncologist is going to have to do a pretty good job, and we'll see if we can use the resources of FMI.
What's FMI?
Foundation Medicine.
Okay, right. Okay, gotcha.
Okay. But we'll see we will definitely see what we can do. and I'll get on that tomorrow. As far as the abiraterone is concerned, again, I don't really know the difference between the costs of the generic and the other one. At one point in time, it wasn't that much because they could hold on to their old pricing for 6 months, and I think that 6 months might be up right around now.
Right.
But the other thing that you'll need to know is what it's going to cost you, what the abiraterone is going to cost you.
Right.
Have you talked about that?
Well, no, that's why it's still in process. You know, they're gonna call me once they find out what the deal is. They have to coordinate with the insurance company. They have to make sure they have the straight order from the doctor. There was some confusion about the dosing. Originally, they gave me 1 day, and I said no. That's because I did talk to Alliance, which is the specialty pharmacy, and I go, that's no good. I need 30 days minimum. And they said, oh, well, we'll need to check back with your doctor because they couldn't read her order. They couldn't read her handwriting. I've lost my train of thought, Rick. What was the question?
Okay, so the train of thought is, what is going to be your responsibility on the abiraterone? For most men in the past, the copay on the abiraterone was about $2,000 a month, or less, depending on the insurance. Having said that, it's similar situation to the Xtandi, but you were able to get your Xtandi copay down to $30, right?
And I got the company to pick up the $30. So it was zero. Yeah.
Okay, so let me tell you that the Xtandi copay under normal circumstances is around $2,000 a month.
Okay.
So you may have to, however you did it with the Xtandi, you may have to do the same thing with the abiraterone.
Right.
Right?
Right.
But don't be surprised if they tell you initially. Now, if the generic is out of the protection period, what do they call that period, Len? When the drug can be, it goes generic.
The 6-month exclusivity.
Right. So if it's out of the 6-month exclusivity, it should truly be a generic, and it should be covered like a generic drug. Although it still, I suppose, could be tiered. I just don't know.
Yeah. Well, the fact that they're talking about the generic tells me that they are talking to the insurance company, and apparently there is enough of a difference. But again, I'm still waiting to hear. You know, they've got to do a lot of calling, and right now I'm kind of out of that part of it. I'll hear, and then I'll make. They're not going to send it until I tell them to send it. If they tell me it's going to be $2,000, I'm going to say no. Sorry, I can't afford that.
Len, we haven't heard anything adverse about the generic abiraterone, have we?
No.
That's what I thought.
Don't forget the patient, what do they call it, Rick? The patient assistance programs.
And yeah.
Yeah, I don't know if they have any money right now. They may, it's late in the year and they usually run out of money, but you could check it, but you can't do that until you know.
Right. Exactly.
And then that would be with, what I can do is I can see what I could do for you at Janssen. But I don't want to go there until we know, it may be a non-issue. I don't want to open the issue.
Right, exactly.
But I may be able to get a concession out of Janssen for you for the real stuff.
If my, Medicare didn't cover any of the Xtandi, it was all Blue Cross. So if they covered that, all but $35, and presumably I'll get a similar deal for the Zytiga.
Well, when you say Medicare didn't, it was all Blue Cross. You mean Blue Cross picks up your supplement, right?
It's my secondary insurance, but I don't have. It's not. Medicare does not cover medicine. It
Right.
covers shots and infusions, but not pills. So,
Right.
I mean,
Right.
Medicare was out of it completely, but Blue
Right.
Cross covered the whole thing except for $35, and then the company paid.
Okay.
So I'm assuming I'll get a similar.
Right. So it's Plan D. So I would think you'll get something similar. If that's how they treated the Extendi, that's probably how they're going to treat the abiraterone. And if it's generic, it's going to be even easier.
That's
So
what I'm
hopefully that's going to be a non-issue.
Right.
So, you know, the only thing that concerns me is it's just taking a while for them to come up with the approval, because we need to get you onto it. That's what we need to do.
Exactly. Because I am, I still have a few days left of the Extendi, and if I run out of that, then I won't have anything. So it is kind of critical. And of course, this is a bad time of year because of the holiday and all that stuff. A lot of places are closing early, and I know my oncologist is. So.
Guys, do you mind if we just talk to Jake alone? We have something else, so we'll call it a day. We've sort of ebbed away, and the next meeting is going to be next Tuesday. So.
Okay. Hey, good luck, Jake.
Thanks, Dennis. Talk to you soon.
Have a good one. See you next week.
Bye.